different professionals. We have mental health counselors, we have school staff, we have members of the START team, we have 2 members of our National Center for START Services team, and we're lucky to have all of you. Dr. Kent and I will be conducting the training. I am the clinical director for the Region 5 START team, Elise Scora. Dr. Kent, would you like to introduce yourself?
Hey, I'm excited to be on the list of key people that gets introduced. There you go. Yeah, I'm Andy Kent. I'm the medical director, very professionally coming to you from a small child's bedroom in the top of my house. But hopefully this will be interesting for everybody. And it's a bigger group, but we do like questions. We do want it to be as informal and helpful as possible. So feel free to jump in at any point.
Yes, definitely. We definitely want as much interaction as possible, so ask questions throughout today's training. And as I said, we will start with hearing from Dawn Wilson, one of our Suffolk team leaders, who is the coordinator on the case that we reviewed in December. So Dawn, do you want to give just a brief overview of the update on Betty?
Okay, good morning, everyone. So just to remind you, last month, I can't believe it was a month ago, but that's what the holidays will do to everybody. So we reviewed Betty, and just to remind you, Betty was diagnosed with moderate ID, CP, anxiety, PCOS, Hashimoto's disease, MTHFR mutation, and hypothyroidism. I have to do that slowly so I don't mess it up. And we reviewed that Betty currently lives in her family home and has very limited support. If you remember, she has a medical indemnity fund supports her because of malpractice at birth. And that created huge barriers systemically for her gaining access to medical care. We were able to get her into a clinic in Nassau County, which she actually just started. She did her psychiatric intake in the beginning of January, and she did her medical intake also that same week. Since that time, she has follow-up appointments, and we are in the process of working with the practitioners on the recommendations that were discussed at last CET. And just to review those with you guys, we had recommended an efficacy test for the MTHFR mutation, the introduction potentially of L-methylfolate, looking at her diet, and that's something I've already discussed with the mother and actually started food tracking so that the mother can start looking at her diet right now and what she's eating and what she's refusing so that we can consider a diet with decreased folic acid and also check her homocysteine levels. We also discussed the introduction of, I'm going to butcher it, so sorry, methanine. I could spell it, but I can't say it. Supplement. So that's something we'll also be discussing with the practitioner. And then also I confirmed that she is not on generic Synthroid. She is on the brand name, which was a concern that was brought up. Her next follow-up is scheduled for the first week of February. I am participating in that appointment. And hopefully we can further clarify some of these recommendations that mom is on board with, discussing with the practitioner, and hopefully move the system forward both psychiatrically and medically, because we do feel the combination right now needs to be dissected and better understood for diagnostic clarity.
Absolutely. Thank you so much, Dawn. And just yesterday, we were able to add her to our resource center list as we're working through some barriers with her budget. So that will be a very great opportunity in the coming months as well.
Absolutely. And I'm appreciative of everybody working so diligently on that front, not giving up on it. So.
Absolutely. Andy, did you want to add something? I saw a hand.
Yeah, I just wanted to tell people you didn't butcher it. That's a hard thing to say. Methyl tetrahydrofolate reductase, that's MTHFR. Bottom line, everybody, Deplin is L-methylfolate. People with that mutation can't take folic acid, convert it properly into their brain where it gets used. So you could eat all the leafy vegetables till the cows come home. It's not going to help. So what we do is we're able to give the Deplin or L-methylfolate, and it could have a very huge impact on behavioral health symptoms. It could cause a reduction in anxiety, it could cause a reduction in depression, and it actually is FDA approved for depression. So it's a huge find on people, and it's something that should be considered in our population.
Absolutely.
Thanks for making it look easy, Dr. Kent, with the,
And for anyone that wasn't with us last month, the recording of the clinical education team where Dr. Kent and I presented the endocrine system with a focus on thyroid conditions and MTHFR mutation is available on our YouTube channel. If you go into YouTube and just search New York Start Region 5, our CETs over the last couple of months, the recording of those are on there. This one will be added as well. And as well as a plethora of meditation videos, yoga videos, educational videos that have been recorded over the last year, specifically since the start of COVID. We built that YouTube channel. So that's going into YouTube and just searching for New York Start Region 5, and those resources and the more recent CETs are available to you there. And if you want to share this with any colleagues, this recording will be uploaded today as well. Thank you so much, Dawn. So we are going to take about 10 minutes or so to review the case record for today. The topic for today, as you all are aware, is the impact of traumatic experiences on obsessive compulsive disorder. And the case, Paul, is one that we are reviewing to present this topic. So Heather prepared a very well done case summary for everyone. So I'm going to give about 10 minutes for everyone to review that case summary, and then we will come back together. Heather will provide an overview, expand on some of the areas of interest, and then have an opportunity to answer anyone's questions that may come up. And then we will move into the training portion for Dr. Kent and I. As we said, any questions during this process, please ask. And we will hopefully leave this training this morning with some recommendations for Paul's system specifically as well. So take about 10 minutes to review the document, and we will come back together to hear some more. Thanks, everyone. Okay, most people have rejoined us on their cameras, so we will move forward. So I'm going to turn it over to Heather Strine, who is the coordinator on this case, to review some important factors of the case and then open it up for questions as well. Heather?
Hi, everyone. Thank you guys for coming. I'm excited to introduce Paul to you all. Paul is a kind, helpful, and resilient young man who lives in Suffolk County in his family home. He lives with his mother, his father, and older sister, and 2 small dogs. Paul has a close relationship with his family, but especially with his mother. He often visits his other sister and niece and nephew who live locally as well. Paul has several community habilitation staff that work with him throughout the week, all of which he has a very positive and encouraging relationship with. Throughout his week, Paul often enjoys spending time with his staff, either in his home or in the community. He has a particular love of music and spending time going out to eat or sitting by the water, as this is what helps him feel calm. He was referred to START due to increases in anxiety that often led to behavioral health concerns such as verbal aggression, such as yelling, and suicidal ideation with no access to means. He would often express suicidal ideation in the context of a panic attack that would often lead to utilization of emergency services to assess for safety. This would happen both in the family home and in the community when experiencing heightened anxiety or frustration. The family also reported concerns related to mental health symptoms and requested diagnosis and treatment plan assistance. Paul's main presenting concerns are related to his severe anxiety and OCD symptoms. He reports having an increase in anxiety at an early age when he was enrolled in school, and school reports often indicated he would self-isolate throughout class and reported he felt different from others. He was not interested in socializing with others and often did not understand jokes. In regards to his OCD, it is reported that these concerns started at an early age as well, when he would rearrange pictures in the house and regularly wash his hands. Currently, he regularly engages in routines that take up a majority of his day or night to complete. He will engage in hand washing, long showers, locking doors, checking the windows, counting rituals, and more. If he is unable to complete the rituals or routines, he will experience an increase in anxiety and frustration, at times leading to verbal aggression or suicidal ideation. Paul was a victim of bullying that started when he was in elementary school. It is reported that the increase in OCD symptoms and anxiety occurred around this time as well. He experienced teasing from other children in the class and would have negative experiences with other children and teachers as well that would strongly impact his day and comfortability within the class. The mother often makes note of an extreme incident of bullying where he was locked in a bathroom stall and videotaped. Although he received one-on-one supports and was moved classrooms several times, the bullying followed him throughout his school years. Ultimately, the mother decided to place him in a life skills and vocational program through school, where he was able to obtain a job and job coaching in the community and no longer interacted with the bullies. This trauma has had a substantial impact on his current functioning, as he often experiences frequent panic attacks and sometimes fears social interaction or community engagement, as he believes he will run into a bully. This has continued to have an impact on his life in the present day. More recently, while Paul was attempting to seek supportive employment in the community with a job coach at a local store, he experienced a panic attack and left the job on the spot due to extreme fear of running into a bully from his school. Since then, his OCD symptoms have increased in frequency and often increase at times he is experiencing this heightened anxiety surrounding upcoming appointments or changes in his schedule. Paul is also diagnosed with attention deficit hyperactivity disorder, autism spectrum disorder, and a mild intellectual disability. He was diagnosed with ASD at a very young age, and the family made note of concerns related to developmental milestones and regression in his skill development. He received early intervention services throughout his childhood and received services throughout his time in school. He often experiences sensory sensitivities, especially to loud noises, certain clothing, and to different foods. Additionally, he has difficulty when his day is not structured and has intense overfocus and rumination on certain subjects or topics. Paul also experienced difficulties remaining on task and remaining attentive to tasks, which resulted in obtaining a diagnosis of ADHD. Paul also experiences communication deficits aligned with his executive functioning difficulties, where he has difficulty processing information, especially when others talk at the same time as him. Paul's parents utilized a variety of different providers and services to assist in his care. The parents obtained a lot of evaluations, and Paul tried a variety of medications. However, services were often changed and medications were changed or stopped due to concerns for side effects related to weight gain and suicidal ideation. Paul eventually stopped all medications due to these concerns. Currently, he is regularly seen by a psychiatrist, but is currently on one as-needed medication to assist in times of increased anxiety. Although education has been completed and is ongoing with the mother, they have been hesitant to explore medication management due to fear of potential side effects. Outside of this, he receives CBT therapy and has obtained a job where he is able to showcase his strong vocational skills. Paul's family also has a strong and extensive mental health history and ASD history, which indicates a strong biological component within the family. Paul's father has been diagnosed with OCD and experiences symptoms associated with PTSD. His mother experiences anxiety, and his sisters both are diagnosed with OCD and ADHD. As you can see through the EcoMap, a majority of Paul's supports are paid supports. Although he has a beneficial relationship with each of his ComHab staff, special attention should be made to him developing more natural relationships and building upon his engagement in the community. It is important and an especially important goal of Paul's to develop further natural supports in order to expand his support network and confidence in maintaining friendships and relationships with others, something he was not able to receive during school. Lastly, it should be noted that Paul's mother is the main person involved in all aspects of his care. Although she has a positive relationship with all providers, she sometimes has difficulty understanding each role, as well as following through with tasks, due to this heavy responsibility, personal stress, and potential for burnout. She also experiences her own anxiety concerns that sometimes impact Paul throughout the day. So overall, that's Paul. If anybody has any questions, definitely feel free to ask.
Heather. Any questions from the group regarding the case thus far?
I don't know if it was asked or mentioned, but has Paul had gene site testing?
You're muted, Heather.
Sorry. Yes, he has. He had it a couple years ago, and then recently when he started seeing a new psychiatrist, he obtained it again. Nothing really particular was found with it. In the past, he's been on a lot of SSRIs, which we thought may have had some sort of interaction, but none of that was shown on the gene site testing.
Thank you, Heather.
Previous medications I know created like a lot of, the family thought there were a lot of side effects involved with those medications. Were there like specific times that they were able to tie the medications to the side effects, or were the side effects something that kind of go throughout his lifespan and just happen to be during the time of the medication?
That's kind of the second part is what I kind of have observed, throughout his more stressful time when he was in school, he was experiencing a lot of suicidal ideation, and he also just happened to be going through a lot of different medication as well. But, that kind of trauma, both on the mom's end and Paul's end, kind of impacted their comfortability with medications moving forward. So just ongoing education, I think, is really important.
Yeah, I mean, it's unfortunate if he's not benefiting from medications that could actually help him. So yeah, just a thought.
Well, part of what we did when we sat down with that family, we did a visit, was to exactly what you said, Nicole, go over that when you look at a medication history, you got to take into account the other variables. And when we read on a piece of paper that says, try this, this, and this, bad reaction, we have to be careful to define that, because otherwise we could rule out all the medications that could potentially help. So I saw that as part of the systems intervention, is to explain that and cut away to what still could be an option looking at down the road. And frankly, what Heather brought up too with this family was to help the mom, even though she wasn't the identified individual, to help her kind of get a sense of what might let her be more comfortable and maybe even seek her own care and her own anxiety reducing interventions.
Dr. Kent, really quick question about medications, because you're the go-to guy. So I'm wondering, for something like treatment of OCD in the situation that Paul's experiencing, obviously an SSRI would be one of the first things you'd consider. How would an SNRI work, and would it be helpful or not helpful for someone with this type of diagnosis? I was just wondering as I was reading the CSE.
Well, you're just going to have to wait for slide number 17, I think.
Oh, darn, I don't know if I can wait that long.
Getting ahead of us, Nicole.
Sorry, okay, I'll wait.
Yes, we are going to explore treatment and supports for a case just like Paul within our presentation. And, you know, I think what Dr. Kent pointed out too is it was just before the shutdown with COVID that Dr. Kent and I and Courtney, the team leader, and Heather were able to sit down in Paul and his mother's home and really meet with them one-on-one and provide just an opportunity to answer questions and review the history with them. And like Dr. Kent said, kind of discern of, was it the situational, the bullying, the trauma experiences, was it a true side effect, and assist her in just opening her mind to what could be helpful for Paul. And it's also helpful for her. And I think that she got a lot out of it as well. And we might maybe need to revisit those types of meetings for Dr. Kent and I to join the system again. I think it was really helpful. And it did open her eyes to the PRN that he's now on, which is a step in the right direction. So are there any other questions before we jump into the training?
Just really quickly, I was curious if there are any members of Paul's team with us today, and sort of what, you know, what their observations are in terms of work, whether it's at his work program or other forums, if they're here.
Unfortunately, they weren't able to join us. One of his main comhab is working with him at this time. So the main comhab was not able to join us, and the others all have day jobs, as well as the care manager works an off schedule due to other work responsibilities. So Heather and I actually just spoke this week about recreating this training, using the recording and kind of recreating it for some of those key members of the system so that they can benefit from the information. And we also discussed this mother is so open to education and support that we can adapt some of the information we present here and even potentially bring in Dr. Kent and do a little bit of an adapted training on this topic, as we do perceive that the system doesn't fully understand the overlap of his traumatic experiences and his OCD and how they play a role together, which is obviously the whole purpose of today. So unfortunately, we were not able to have the system due to their other responsibilities join us, but we do plan to present this to them at another time and gain their input and review the recommendations and move forward that way. Okay, so I'm going to share my screen with the PowerPoint. And we will get started. As Dr. Kent said, for anyone that has not been with us before, we definitely don't need you to hold your questions till the end. Feel free to unmute, ask a question on the slide. We'll try to stop periodically because it's a lot of information to see if there are any questions, but don't hesitate to stop us and ask some questions. Okay, so we will get started. So what is OCD? So obsessive compulsive disorder is a mental illness that causes repeated unwanted thoughts or sensations, obsessions, or the urge to do something over and over again, or compulsions. Some people can have both obsessions and compulsions. OCD isn't about habits like biting your nails or thinking negative thoughts. An obsessive thought might be that certain numbers or colors are good or bad. A compulsive habit might be to wash your hands 7 times after touching something that could be dirty. Although you may not want to think or do these things, someone with OCD would feel powerless to stop. Everyone has habits or thoughts that repeat sometimes, but people with OCD have thoughts or actions that take up at least an hour a day. As Heather pointed out, Paul's habits pretty much take up his whole day. It's very hard for him to move on. They're also beyond control. They aren't enjoyable, and they interfere with work, social life, or any other part of life. OCD also comes in many forms, but most cases fall into 4 main categories. The first is checking. So this is such as locks, checking alarm systems, ovens, light switches, thinking that you may have a medical condition like a pregnancy or schizophrenia. The second category is contamination, which is a fear that things might be dirty or a compulsion to clean. Mental contamination involves feeling like you've been treated like dirt. Symmetry and order is the third category. And this is the need to have things lined up in a certain way. And the fourth category of OCD is ruminations and intrusive thoughts. These are obsessions with a line of thought. So some of these might be violent or disturbing as well. There are many risk factors towards OCD. It includes a parent, sibling, or child with OCD. As Heather discussed, his father and his siblings all have OCD. Physical differences in certain parts of your brain are also a risk factor, which Dr. Kent is going to go into specifically in a few slides. Depression, anxiety, or tics, as talked about, there's a lot of anxiety in his family as well. Experience with trauma is also a risk factor, and discussed his experience with trauma and bullying has been very pervasive throughout Paul's life. Also, a history of physical or sexual abuse as a child is a risk factor.
All right, I'm going to get into a little more specifics and give some case examples. Obsessions are recurrent and persistent thoughts, impulses, or images experienced in some moment of the disorder, and they're considered intrusive and inappropriate, and they cause significant anxiety and distress. It's interesting, and having treated so many people through the years, because the brain in this disorder often seems to come up with what would be the worst thing it could possibly come up with. You know, how could it be the most damaging and hurtful to the individual? So that being said, the themes we often see are violent, sexual, and generally things that a healthy superego or conscience would really abhor. So I'll give a couple examples. I had this one woman who had a recurrent thought that she was going to be sexually active with her father and have the baby. Now, she had no interest in this. He had not abused her. There was no trauma. It was just this ego dystonic, horrible thought, and she could not get it out of her head. I had a man who was not gay, and he had an obsessive thought that he would have sex with the local priest. Every time he would walk by the church, he would be uncomfortable. He described it as being disgusting to him, infuriating to him, could not get the thought out of his head. The actually only advantage in that one was he got me to write a note that he didn't have to go to church for a while until we got the meds to work. So he got a free pass on that one. But you can see the theme. These were things that were really abhorrent to the individual. Violence is hugely common. I've had a ton of patients. I'm going to stab my parent, or I'm going to push someone in front of a train. And they get very tense when they're around the individual. And I have some people that can't go into the kitchen because there might be a knife sitting around, and they can't pick it up and eat at the dinner table with a sharp object because the loved one is sitting across the table. Now, these are non-violent individuals who love the family members, but again, it's an intrusive thought that just gets sort of broadcast into their head, and they can't get rid of it. Now, we think of obsessions as thoughts, but they could be visual. I have a young guy in my practice who every time he goes to kiss a woman on a date, he will visualize male private parts. And I cannot tell you how he describes how unpleasant it is, how odd it is, and embarrassing, but it just automatically pops into his head. And it took a long time for him to get past thinking, am I gay? Am I not gay? You know, what's wrong with me? Why am I having this? Until we've kind of worked with him to realize it's not him believing this. It's not a truth. It's not even a belief. It's this passing intrusive thought that he couldn't help.
Dr. Kent, I have a quick question.
Yeah, sure.
Is there ever a concern that somebody with these thoughts will act out on it? Or is it really just the obsessional thinking?
Well, that's obviously, you always want to assess that and make sure it's not a psychotic intrusive thought, not something they truly want to do, and that they have a good cognitive understanding of it. But in most of these individuals, it's fairly clear they have no desire. It's the last thing they want to do. But you're right, that's part of the differential diagnosis between, you know, obsessive thought and perhaps a homicidal intent, a suicidal intent. So it has to be distinguished.
Okay.
Now, as Elise brought out, these thoughts and impulses are not merely excessive worrying about real life problems. These are way past that. The individual generally attempts to ignore or suppress these thoughts or tries to neutralize them through other thoughts or actions. And what separates them from psychosis, which is kind of what you were bringing up, is that they know it's produced in their mind. They don't think it's coming from outside their head or, you know, some kind of paranoid source. They really want it to go away, and they really see it as what's called ego dystonic. All right, compulsions. These are defined by behavior or mental acts of a repetitive nature, which the individual sees themselves obliged to perform in response to an obsession or in accordance with certain rules that have to be followed. It's hard to come up with an example specifically because I've seen so many, and they could range from annoying to severely impacting an individual's life. Give an example of a young woman who had a compulsion. She had to do everything 8 times. That was just her magic number. She had to tap her cigarette 8 times to get rid of the ashes. She had to turn the kitchen sink on and off 8 times. And the final straw that brought her to me for medicine was she failed her road test a couple times because she had to check her mirror before pulling out 8 times. So you could imagine the driving instructor didn't find that overly amusing and didn't feel it was safe for this woman to be behind the wheel. So that really was starting to impact her life. And as Elise brought up, the time consumption is something we have to assess. I have people that have to put their clothes on and off so many times in the morning or check their lock on their door so many times that they're late for school, they're late for work. It could get into hours. It really could be unbelievable. Bathroom compulsions are very common. They may have to clean or wipe themselves a certain number of times, check that they're clean a certain number of times, and may never walk away feeling that it was done properly. Now, it's a very common cause of fighting in the house because a parent or a caretaker may think that the child or individual is at fault for not getting ready. They may think, oh, they're just being oppositional, or they have the ADD dawdling, that they're just not getting their act together, and they may not be realizing they're responding to these rituals that they truly need to do. Now, the goals of these behavior is to prevent or reduce distress felt by preventing some negative event or situation. These behaviors or mental operations are usually not connected realistically with what the person's trying to neutralize or prevent, and they're clearly excessive. Sometimes, though, the thing they're trying to prevent is even unknown. They'll just say to me, something bad's hanging out there. I know if I don't do this, something bad is going to happen. It could be an identified person. Hey, my mom's going to die, or something's going to happen to my sibling, but not always. Sometimes they just feel if they don't do it, something very vague and bad is going to happen. And last point on this is, remember, it could be internal. It could be counting something in their head, going through a list of random things in their head. So we don't want to assume if they're not doing compulsive acts of tapping, counting, touching, that it doesn't exist, because compulsions can be very personal, very internal, and very disruptive.
Moving towards, for a person with intellectual disabilities, there are a lot of challenges in diagnosis of OCD. I'm sure as you were hearing, the previous few slides, we can all imagine what some of those difficulties might be. Firstly is communication deficit. So people with IDD often have communication deficit in their expressive language. This decreases the ability for self-report. So as Dr. Kent was discussing, if the individual themselves has difficulty telling their providers and their supporters of what's going on for them, it might be difficult to come to a diagnosis and not think it's psychotic or part of their autism or their ID in nature. Sensory impairments may also further restrict their range of obsessive compulsive symptoms, which impacts the presentation as well. Obsessions in the general population, as Dr. Kent said, are experienced as intrusive or unwanted. This does not always apply to individuals with IDD. It really depends on their ability to identify and communicate that concept. Also, compulsions require some abstract thought that may not be possible for the individual with ID, depending on their level of functioning. Also, discuss individuals in the general population may attempt to ignore or suppress the obsessions or neutralize them with other thoughts or actions. This is also a difficult thinking and process for someone with IDD. Compulsions in the general population are aimed at preventing or reducing anxiety or distress, and individuals with IDD may not be able to articulate the aims of their behaviors or mental acts. Doesn't mean it's not attempting to neutralize, but that communication factor, of course, comes into play. Individuals with ID may also be unaware of societal disapproval in the actions that they are presenting. So this knowledge may not serve to reduce the behavior or symptom as it would with the general population. A really big area that is sometimes overlooked is aggression. So aggression may be the presenting issue of concern for the individual with IDD, but with careful history and review, we can understand that potentially the etiology of that aggression is actually an OCD symptom related to potentially a caregiver or supporter attempting to prevent the compulsive act and resulting in that aggression. So that's where some of that differential diagnosis, like Dr. Kent was talking about, also comes into play. The aggression might be a symptom in relation to the OCD. And I do believe we see that quite a bit within the START team. Individuals with OCD in the general population can also gain insight into the connection between their obsessions and their compulsions. They can identify the fears behind their anxiety as well as their compulsive behaviors they perform in order to relieve their anxiety. They can recognize the difference between normal behaviors and their own maybe bizarre obsessions and compulsions. However, this is also an advanced skill that may not be possible for all individuals with IDD. OCD patients, they have a lot of comorbidity with autism. So that is also an area that needs to also be considered. You know, autism in of itself has some underlying OCD, the need for structure, routine, order, sameness. So really, again, looking into the etiology and underlying vulnerabilities to make sure that it is an official area of OCD that's above and beyond what might be more normalized in autism. And the DMID really does assist to differentiate and provide some clarity on the diagnoses for someone that does have ID. Someone with autism may also not see their compulsive behaviors as bizarre. So that's something that, again, comes into their ability to communicate and understand the symptoms. In addition, autism and OCD share a number of features. So this does make that differential diagnosis extremely difficult and can lead to overdiagnosis of OCD in people with autism. So we do see that a lot. Oftentimes when Dr. Kent and I do consultations, we really have that conversation of, is it a true OCD diagnosis or is this just inherent into their autism? Does it meet that level of need for a true OCD diagnosis, and reference the DMID and really try to investigate whether it is truly a diagnosis that this individual is struggling with. Both disorders have a fixation on routine, ritualized patterns of verbal and nonverbal behavior, a potential resistance to change. They may have a fixed, highly restrictive interest. So again, that differential can be fairly difficult and is a big area that we look in when we see those diagnoses coming into the START team. So there are a lot of reasons why it's challenging to diagnose someone with OCD when they have IDD. So this is just obviously a quick list, but it is something to always be aware of when you are working with the population in ensuring that they're diagnosed and being treated appropriately.
So we've always known OCD exists, but with newer technology, we can now see where it's happening and realize a little bit better what the patient's dealing with. This is a PET scan, which is a positron emission tomography, and it uses a radioactive drug or tracer to show where the activity is actually occurring. This way you can see metabolism and compare it to a normal control. So it's not just like a CAT scan or an MRI that shows structure, it actually shows metabolic functioning in addition to structure. On the scan, as it gets darker red, you see greater activity, much like if you put a weather channel on and you see like, you know, no rain, light green, light rain, yellow, orange, red, heavier activity. Red being severe thunderstorm. Similar here, that there's going to be more and more activity. So we have a long way to go to understand it perfectly, but there are areas of the prefrontal cortex as well as the basal ganglia and thalamus that seem to be involved. These are the areas where there's major hypermetabolism. And it's important because that's where drug research is going to be, to try to figure out where to target these areas and have a therapeutic effect. And because of the increase in knowledge, there have been cases in severe OCD that did not respond to medicine that, believe it or not, had surgical interventions. Not that I'm recommending that, and obviously it's a more extreme thing, but they've been able to now locate. There's also a case now for something called deep brain stimulation, which they implant a neurostimulator, and it sends electrical impulses through implanted electrodes, and it could actually target specific areas where this is going on, and it can lessen the amount of impulses there, lessen the OCD behavior. And it's not just in psychiatry, they're doing that in Parkinson's as well. So I think this is just, again, sort of an example so we can actually see where in the brain this is happening.
Hey, Dr. Kent, quick question. So with the heightened activity in the red portion, like on the second line of images, does this indicate that like signals are moving quicker within the brain or at a heightened speed or anything like that? Or how, when you say there's more activity there, are you relating to neurotransmitters or like,
Right,
I don't.
there's increased neuronal synapsing, there's increased transport, there's increased communication between the nerve cells. So they're expending energy, they're using the tagged glucose or whatever they are. So yes, so basically what that means is it's less dormant,
Okay.
and more activity is going on. So the person who's perseverating, obsessing, those are the areas where the brain is constantly having that thought over and sending that signal over and over again to the other parts of the brain.
So do medications that are indicated for OCD, such as SSRIs, do they slow that part of the brain down? Because it's my understanding that they increase levels of serotonin, which in my mind, I'm not a doctor, that would make me think that it would move faster.
Well, you have to remember, an increased neurotransmitter doesn't mean increased metabolism. An increased neurotransmitter can have a disinhibitory effect. You know, that could happen to lower blood pressure, that could happen to lower obsessive thinking. So because you're causing a higher level of serotonin, that can have an anti-anxiety effect, a relaxing effect. So it doesn't mean you're going to have more activity that's going to be excitatory. It could be more activity that's inhibitory. So yeah, it gets a little confusing and it's a little more complicated than that.
Yeah.
But it does increase serotonin, but that doesn't mean you're having more, more obsessive thinking and more metabolism in a way that's going to cause increased symptoms.
Okay, thanks. I know it's a weird question, but that's interesting to note. Thank you.
No, not at all. Yeah, it isn't. I don't think it's weird at all.
Yeah, that was a great question. Before we move on into the trauma portion, and then obviously getting into that overlap of trauma and OCD, does anyone have any questions on kind of the overview that Dr. Kent and I provided on OCD, the symptoms, how it presents, the brain scan, etc.?
I have one more and then I promise I'll stop.
No, don't stop. Ask as many as you need.
Does trauma cause an increase in activity in the same portion of the brain, or can it?
You're ahead of us, Nicole.
Sorry, this is a very
yes, we are actually, there's going to be another brain scan that is of a trauma individual that experiences trauma, and we will be going through what that looks like. So that should help answer that question.
Thank you.
You're welcome.
The bottom right one, I think, is of Nicole's brain thinking of her next question.
It is. Clearly, I have something going on, so thank you.
No, that's great. I'm glad that this is helpful so far. Any other questions that have come up thus far? Okay, so we're going to move into trauma. So trauma is an event or series of events or circumstances that can cause physical and or emotional harm to a person. So some examples of traumatic events are neglect or abandonment, such as food insufficiency, lack of ability to meet basic needs, homelessness, death of a parent in childhood, divorce, family life that includes drug addiction, alcoholism, parent incarceration, violence, sexual abuse, physical abuse, emotional abuse, all of the above. Also, of course, bullying, which, as we've talked about, Paul experienced prolonged, severe bullying that really greatly impacts how he experiences the world, both in the past as well as currently. It's also important to recognize that trauma is not what happens to us, but how what happens affects us. So this explains how some soldiers go to war and they come back and they can live a relatively normal life and they're not really impacted by trauma, while others that have experienced similar or the same events while serving our country may return with traumatic symptoms and really need a lot of support in their experience. So the trauma that we experience is really it really affects us based on and is impacted by our earlier experiences that we've encountered. There are also 3 areas of well-being that trauma impacts. So these are physical, social, and emotional, spiritual. There are 3 areas, these 3 areas correlate to 7 domains of functioning. These domains are the sectors that the trauma may impact a person. So they are biological, cognitive, attachment, self-concept, emotional regulation, dissociation, behavioral regulation, and all of these domains are going to be explored in depth in the next slide, so hold tight. Trauma is also a neurodevelopmental insult. So it impacts the development of the brain as well as psychological processes. The traumatic exposure disrupts the development of self-regulation processes, leading to chronic affect dysregulation, destructive behavior towards self and others, potential learning disabilities, dissociative problems, distortions in concepts of self and others. It can also cause a missed opportunity for skill building. So it may cause difficulties managing emotions and behaviors. They can be impulsive. They can have problems with communication, difficulties with reading and writing, health problems, and difficulty building relationships and social skills. Trauma will also get in the way of using skills that may have been previously learned or mastered. This is something we see a lot. We'll hear from systems like they could do this yesterday or last week, and now they need help with it. And some will hear the word that START doesn't like of they're just being manipulative. But trauma really does get in the way of skills that may have been previously mastered. What gets in the way in regard to the trauma might be flashbacks, nightmares, dissociation, anxiety, reenacting traumatic situations, having difficulty understanding new situations, or maybe new situations causing that acute stress response. They may withdraw from others, or difficulty on relying for others to help them. So, impact of the childhood trauma. So this goes back to those 7 domains of functioning. So children whose families, homes, and their environments that do not provide consistent safety, comfort, protection may develop ways of coping that allow them to survive and function day to day. For instance, they may be overly sensitive to the moods of others. They may always be watching to figure out what the adults around them are feeling and how they'll behave or react in a certain situation. They may withhold their own emotions from others, never letting them see, when they're afraid, sad, or angry. And these kinds of learned adaptations make sense when physical or emotional threats are ever present. As a child grows up and encounters situations and relationships that are safe, these adaptations no longer are helpful and may in fact be counterproductive and interfere with the capacity to live, love, and be loved. So first, I'm going to talk about attachment. And relationships. So, and just a plug that this is actually a category for a whole CET next month. But the importance of child's close relationships with a caregiver cannot be overestimated. Through the relationships with important attachment figures, children learn to trust others, regulate their emotions, and interact with the world. They develop a sense of the world as safe or unsafe, and come to understand their own value as individuals. When those relationships are unstable or unpredictable, children learn that they cannot rely on others to help them. When primary caregivers exploit or abuse a child, the child learns that he or she is bad and the world is a terrible place. The majority of abused or neglected children have difficulty developing a strong, healthy attachment to a caregiver. Children who do not have healthy attachments have been shown to be more vulnerable to stress. They have trouble controlling and expressing their emotions and may react violently or inappropriately to situations. Our ability to develop healthy, supportive relationships with friends and significant others depend on having first developed those kinds of relationships in our families. A child with complex trauma history may have problems in romantic relationships, friendships, with authority figures such as teachers or police officers. With Paul, obviously his main trauma was his bullying. But this really did affect and does affect his attachment and his relationships. Luckily, within his family home, he really had a great sense of support and love. As Heather mentioned briefly, the mother was very involved with the school, advocating and really trying to support him throughout. Unfortunately, in some ways, he was failed by the school system, and that bullying really did continue through many, many years. And unfortunately, it really didn't cease until he was removed from the school completely in his older high school years and moved into a life skills program, which when we spoke with the mother and Paul and in reviewing his records, truly academically, he could have stayed where he was. But to end this ongoing trauma, removing him ended up being the best solution due to the continued bullying that the school really was unable to stop. So again, the attachment within his family was well developed, and it appears from our observation as well as the work we've done that a detriment, but it's likely that the trust in authority figures such as teachers and the school administration really did impact him further, as well as the ability to move forward and building relationships and having attachments to others in the community due to that intense bullying that he experienced. Moving forward to physical health. So through infancy, through adolescence, the body's biology, develops. So normal biological function is partly determined by the environment. When a child grows up afraid or under constant or extreme stress, the immune system and the body's stress response systems may not develop normally. Later on, when the child or adult is exposed to even ordinary levels of stress, these systems may automatically respond as if the individual is under extreme stress. For example, an individual may experience significant physiological reactivity, such as rapid breathing or heart pounding, or may shut down entirely when presented with stressful situations. These responses, while adaptive when faced with significant threats, are out of proportion in the content of normal stress, and may often be perceived as others as overreacting or unresponsive or detached. Stress in an environment can impair the development of the brain and nervous system. An absence of mental stimulation in neglectful environments may limit the brain from developing to its full potential. Children with complex trauma histories may develop chronic or recurrent physical complaints such as headaches or stomach aches. Adults with histories of trauma in childhood have been shown to have more chronic physical conditions and problems. They may engage in risky behaviors that compound these conditions, such as smoking, substance abuse, diet and exercise habits that could lead to obesity. Complexly traumatized youth frequently suffer from body dysregulation, meaning they overrespond or underrespond to sensory stimulation. So for example, they may be hypersensitive to sounds, smells, touch, or light, or they may suffer from anesthesia or anaglesia, in which they're unaware of pain, touch, or internal physical sensations. As a result, they may injure themselves without feeling pain. They may suffer from physical problems without being aware of them. Or conversely, they may complain of chronic pain in various body parts for which no physical cause can be found. And we see that quite a bit in our population as well. Moving on to emotional responses. So children who experience complex trauma often have difficulty identifying, expressing, and managing emotions. They may have limited language for feeling states. They often internalize and or externalize stress reactions, and as a result may experience significant depression, anxiety, or anger. Their emotional responses may be unpredictable or explosive. A child may react to a reminder of a traumatic event with trembling, anger, sadness, or avoidance. For a child with a complex trauma history, reminders of various traumatic events may be everywhere in the environment. Such a child may react often, react powerfully, and have difficulty calming down when upset. Since the traumas are often of an interpersonal nature, even mildly stressful interactions with others may serve as trauma reminders and trigger intense emotional responses. Having learned what the world is a dangerous place where their loved ones can't even be trusted to protect you, children are often very vigilant and guarded in their interactions with others and are more likely to perceive situations as stressful or dangerous. While this defensive posture is often protective, when an individual is under attack, it becomes problematic in situations that did not warrant intense reactions. Alternatively, many children may learn to tune out to threats in the environment, which is like called emotional numbing, making them vulnerable to re-victimization. Difficulty managing emotions is pervasive. It occurs in the absence of relationships as well, having never learned how to calm themselves down once they're upset. Many of these children become easily overwhelmed. For example, in school, they become so frustrated that they give up on even small tasks that prevent a challenge. Children who have experienced early and intense traumatic events also have an increased likelihood of being fearful all the time and in many situations. They're more likely to experience depression as well. Dissociation is often seen in children with histories of complex trauma. When they encounter an overwhelming or terrifying experience, they may dissociate or mentally separate themselves from that experience. They may perceive themselves as detached from their bodies, on the ceiling, or somewhere else in the room, watching what's happening to them. They may feel as if they are in a dream or some type of altered state that is not quite real, as if the experience is happening to someone else. Or they may lose all memories or sense of the experiences that happened to them, resulting in gaps in time or even gaps in their personal history. A child may also cut off or lose touch with various aspects of themselves in an extreme case. Although children may not be purposely dissociating, once they have learned to dissociate as a defense mechanism, they may automatically dissociate during other stressful situations or when faced with trauma reminders. It can affect their ability to be fully present in daily life and can cause a significantly fractured sense of self and continuity. Therefore, it can affect learning, classroom behavior, social interactions. It could also appear as if they are simply spaced out, daydreaming, or not paying attention if a child is dissociating, and obviously can't report that. Behavior: a child with complex trauma history may be easily triggered or set off and is more likely to react very intensely. The child may struggle with self-regulation and may lack impulse control or the ability to think through consequences before acting. As a result, complexly traumatized children may behave in ways that appear unpredictable, oppositional, or extreme. A child who feels powerless or who grew up fearing an abusive authority figure may react defensively and aggressively in response to perceived blame or attack, and alternately may be at times over-controlled, rigid, and unusually compliant with adults. If a child dissociates often, this will also affect behavior. Such a child may seem spacey, detached, distant, or out of touch with reality. Traumatized children are more likely to engage in high-risk behavior, such as self-harm, unsafe sexual practices, and excessive risk-taking, such as operating a vehicle at high speeds. They may also engage in illegal activities, such as alcohol and substance use, assaulting others, stealing, run away, and therefore it makes it more likely that they'll enter the juvenile justice system or, as an adult, potentially the criminal justice system. Cognition: so children with complex trauma histories may also have problems thinking clearly, reasoning, or problem solving. They may be unable to plan ahead, anticipate the future, and act accordingly. When children grow up under the conditions of constant threat, all their internal resources go towards survival. When their bodies and minds have learned to be in chronic stress response mode, they have trouble thinking a problem through calmly and considering multiple alternatives. They may find it hard to acquire new skills or take in new information, as I discussed earlier. They may struggle with sustaining attention or curiosity, or distracted by reactions to trauma reminders. They may show deficits in language development, abstract reasoning skills, and children who have experienced complex trauma may have learning difficulties that require additional support in the academic environment. And really thinking about the cognition, as well as with people that we serve at through START with IDD, there's obviously a lot of overlap to things that we see with their ID levels, with their autism, with executive functioning deficits. So this goes back to something we talked about earlier about that differential and really trying to understand. Oftentimes when we're reviewing cases in consultation, we really focus on, was there trauma? Have we done a trauma assessment? Is there something else going on here, or is this solely their IDD? So the cognition piece and the behavior piece especially are really important in that differential. And I believe, self-concept and future orientation. So their self-worth from the reactions of others, particularly those in closest to them, are of concern. The caregivers have the greatest influence on a child's self-worth and value. So abuse and neglect may make a child feel worthless and despondent. They may blame themselves for what occurred to them. It may feel safer to blame themselves rather than recognize their caregiver or the person that was in charge as dangerous or unreliable. Shame, guilt, low self-esteem, and poor self-image are common among those with complex trauma histories. And lastly, the long-term health consequences. So we talked about the biological side, but there is a long-term health consequence. So traumatic experiences in childhood have been linked to increased medical conditions throughout their life. For anyone has seen the Adverse Child Experiences study, it's a longitudinal study that explores the long-lasting impact of childhood trauma into adulthood. It includes over 17,000 participants, ranging in from adults from 19 to 90. Research has gathered medical histories over time while also collecting data on the subject's childhood exposure to abuse, violence, and impaired caregivers. Results indicated that nearly 64% of participants experienced at least one exposure, and of those, 69% reported two or more incidents of childhood trauma. Results demonstrated that the connection between childhood trauma exposure, high-risk behaviors, chronic illness such as heart disease and cancer, and early death. I also want to add, before being able to stop speaking for a minute, is that New York START Region 5 collaborated over the last year and a half or so, actually a little bit longer than that, with New York START Region 3 on a trauma project, a research project, which is in its final stages. We're writing our report now. And we reviewed 80 clients between both regions, and 96% of the population was found to have at least one trauma experience and meet criteria for PTSD, full diagnosis, which was a huge number. We expected it to be high. Of those 80, only 4 actually had a PTSD diagnosis going into the study. So we are really excited about the data and moving forward and really supporting the systems in really assessing the trauma that the individuals that we serve experience and how that is playing a role in the symptoms that they're displaying and how we can best support them. Over to you, Andy.
So fast. All right, so I'm going to follow up on the impact of trauma on sensory input, which I think is important because it's often the disconnect in our support systems where the end result behavioral health symptoms are seen and reacted to and not always understood where it came from. So the key structure here that I want to talk about is the limbic system, which is marked in green. It supports many functions, including emotional behavior, long-term memory, formation of memories, and olfaction. Olfaction is the sense of smell, and its location close to the limbic system is vital, and it'll come back to see why when I further along in the slide. So basically, the limbic system processes input from sensory systems. So in other words, it takes into account what we hear, what we see, what we taste, what we smell. Now, the location of smell is low down and in our more primitive part of our brain. So it's very essential in terms of our emotional regulation. Sensory input is valuable, but think about for a second if sensory input's not oriented to time. All right, that sounds kind of like a weird thing to say, but if we hear a gunshot or if we smell a fire, if we don't know it's an old sensation, we're going to act differently. We're not just going to think, oh, that's a bad memory. You know, oh, I remember the time when that happened. No, you're going to react to it like it's happening at that moment. So you might look psychotic or you might look oppositional because you're responding to something that you believe is on your doorstep at that moment, where the people around you have no clue because it's clearly not on your doorstep at that moment. So think about a person who's trying to escape. If they feel threatened, they may experience loud sounds that may be associated with a memory of impending danger. So there's the capacity to get confused and not be sure if it's an old danger or an old danger come back to visit once again. They may smell something that not only a reminder of the past, but they actually then can believe they are in the past. And I think you mentioned something about soldiers before. When I worked at Walter Reed Naval Hospital, or Bethesda Naval Hospital, now famous for Donald Trump drive-through, we had a PTSD clinic there, and it was fascinating. And I remember I had a guy who had told me that when he had certain smells and dampness in a summer night, it would remind him of being in Vietnam. And he would become hypervigilant, dangerous, and he would lash out at those around him. And he actually, on one warm evening in his bedroom, woke up sort of stunned and beat up his girlfriend. So it was a disaster. It had a huge impact on him, but it was the trauma screwing up with his sensory input, feeling he was experiencing something at that moment that he was not. And because of the olfactory system and where it's located, and how I said before, it's a primitive sense, it's so tied to emotions. Anybody ever wonder why perfume business is $1 billion business, right? Because the perfume that's going to be involved in, romantic feelings and all kinds of stuff that brings out emotions, and the amount of research that has been done on that is incredible. Another funny thing, think about when people sell a house, what do they tell you to do? Bake bread, bake cookies, apple pie, and then when people come in, they're experiencing a sense of warmth, of family, of security. So that area of the brain is very associated with primitive emotions. And when reality testing is off, when trauma plays a role, that sensory system is really bringing in that information, sending it to the higher portion of the brain, but leaving out one important factor: when it actually thinks it's occurring. Now, another kicker to this story, think about now if you have somebody with trauma, with their sensory systems off, and they have dementia. Now we have a whole nother factor to worry about. So I've worked with dementia patients who get severe disorientation when they hear a loud sound, and they may revert back and feel that they're experiencing something that occurred in the past. This is important to take into account because the individual is not truly accurately evaluating the extent of the threat. In their mind, they're thinking it's going on, and they're going to become very hypervigilant. I had just one quick example, an elderly gentleman who lived through Nazi occupation as a little guy in Germany. And when he would hear loud knocks at the door or loud noises, he would go running around to find his gun, which he no longer owned, and he would go hide under a table. And it turned out that that's what his family would advise him to do when the Nazis would knock on the door because of fear of getting caught. So he really, to use a very non-clinical term, crazy. Was he crazy? Well, yeah, in 2021, he's crazy. But if he's experiencing that as 1939, maybe it's not so crazy to try to hide and to get away from from what he experienced as loud noise, which was associated with danger.
Mm-hmm. I want to add another case example. When I worked in a residential school a few years ago, we had an individual come to our program. He had autism, he had moderate ID, among others, ADHD, I believe, as well. He had significant trauma, sexual abuse by his biological father, physical and emotional abuse by his mother, his biological mother. In a previous residential program, he experienced abuse and neglect from the staff and the caregivers. He actually came to us in the middle of the night when the program he was residing at was basically invaded by the FBI for extreme levels of abuse and neglect. And Bob knows exactly what program I'm talking about. So a lot of trauma from everyone that really was supposed to be supporting this young man. Even though I was the associate clinical director at the time, the case came to me just because of how extreme his trauma was. We had him for several months, and we were really able to help support him, provide him appropriate therapy. We were able to identify natural supports in his life that we could appropriately engage and that were supportive to him. And things were going really well. We called them cottages that they lived in on the campus, and a new staff member joined the cottage, and he reverted back to very, very, old symptoms that we had really thought we moved on from because he was doing so well with us. And it took us a really long time and a lot of therapy and work to really assist this young man in identifying what it was about this particular staff. And it ended up being his cologne. The cologne that he wore was the same cologne his father wore, who was sexually abusive to him for many years. And it was a very intense process to come to that. And we had samples of things, colors, we had pictures of people, with his intellectual level, it was very hard for him to just come out and say that. So there was a lot of investigation, but it ended up being the cologne. And that goes back to the sensory input that Dr. Kent was exploring. And once we were able to ask this staff member to change his cologne and not really wear any cologne, he was fine. And he ended up working very well with this young man. We were able to reintroduce him to the cottage. And it was a really great learning experience for the staff, as well as this young man that experienced that. But again, that goes really far with what Dr. Kent was just talking about. And it also talks to how difficult it was for this young man due to his deficits in communicating that. And it really fell on us to understand what this was about for him. Okay. And the next brain scan.
Yep, I love my scan pictures. So here's
We love our scans.
Another PET scan. Now the brain on the left is a healthy brain of a normal child, and you see regions of high and low activity again with the color variation. On the right is a brain of a Romanian orphan who was institutionalized shortly after birth and was abused. What's so interesting is the temporal lobe and other higher level structures are not fully formed at birth. So as Elise was talking about before, the trauma affects it differently in a child because it doesn't allow it to develop appropriately. If an adult is traumatized, well, at least their brain is developed to that level. If a child is traumatized, that area has not even grown yet. So you're going to impair its development in the first place, and the results are going to be devastating. So what will happen is, because of the major damage, you won't see people react to stress as an adult in appropriate fashion. Now, the temporal lobes here are circled, and again, they're adjacent to the limbic system, which we've talked about on the other slides, is very involved in emotional regulation. So they send it to the temporal lobe. The temporal lobe is not able to appropriately process it, and then the person can't handle it appropriately. In the healthy brain, you see a lot of activity, where in the abused child, you see very, very little going on in that area. So it's very complicated, but there's a very significant connection between sensory system, limbic system, and then to the temporal lobe and frontal lobe higher levels of functioning. So I just thought, again, it's complicated, but I thought this was sort of a very good picture to just demonstrate how little activity is going on in the area of the brain, which that's what it's functioning to do, is to handle emotional regulation.
Thank you.
I was just going to say, Nicole, did that answer your question? So before we move on to now the link between OCD and PTSD, after we've done some thorough overview of both conditions separately, are there any questions regarding anything we've gone over thus far? Okay. So research shows that the likelihood of a person diagnosed with PTSD developing OCD within a year is approximately 30%. That's really high. Between 4% and 22% of people with PTSD also have a diagnosis of OCD. This figure is much higher than the current occurrence of OCD in the general population, which is around 1%. In fact, recent research discusses that OCD and PTSD are two conditions on the same continuum. With both conditions, a person has intrusive thoughts and then engages in attempts to neutralizing behaviors to reduce their anxiety from the distressing thoughts. In PTSD, a person often tries to neutralize their thoughts by suppressing them or engaging in other behaviors like isolation and avoidance. Compulsions are the neutralizing behaviors in OCD. While compulsive behaviors like checking, ordering, hoarding may make a person feel more in control, safe, and less anxious in the short term. In the long run, these behaviors do not only inadequately address the source of their anxiety, they may also increase the amount of anxiety someone experiences. People with OCD that develop after a trauma show a different pattern of symptoms. So they may have more suicidal thoughts. They may have self-mutilation. They may have panic disorder with agoraphobia. They may have more hoarding, compulsive spending, and a greater level of anxiety or depression. Research in 2003 by Gershny suggested that there's a tremendous overlap between the symptomology of both OCD and PTSD. As I discussed, both are categorized by recurrent and intrusive thoughts that are experienced as fear and anxiety inducing. This researcher discovered that as PTSD symptoms reduce, OCD symptoms increase, such as OCD symptoms are OCD symptoms are treated, PTSD symptoms may take over. They argued that OCD symptoms do not appear to replace the PTSD symptoms, but rather OCD symptoms are used to cope with, reduce, and avoid the trauma-related symptoms and memories. So furthermore, the link between OCD and PTSD have been evidenced by a significant amount of researchers. Okay, so there are also several theories of something called post-traumatic OCD. Bador in 2012 is a researcher that suggested the role of disgust in both OCD and PTSD as a significant and worthy of future research. Those who experience traumatic victimization, such as sexual, physical, or criminal assaults, experience intense feelings of disgust. Feelings of disgust can lead to both PTSD and a contamination-based OCD. These feelings lead to a need to remove oneself from sources of contamination and may result in hand washing, showering, and avoidance rituals. The intrusive recollections and thoughts that are a result of the traumatic event may become generalized to other life experiences as well. They no longer appear to be conceptually associated with the traumatic event, but rather take on the typical patterns of obsessional thoughts found in OCD. Nevertheless, they can be traced back to that original traumatic event with time. Rockman's theory of betrayal and contamination in 2010 in Contamination Preoccupation adds additional evidence for the link between traumatic experiences and OCD. So although betrayal and physical contamination are not conceptually similar, there's sufficient evidence that has been found that betrayal is relevant to anxiety disorders, OCD, and PTSD symptoms. Other researchers have suggested that early life experiences created schemas and assumptions about the world. If these early experiences are seen as adverse and traumatic, children develop beliefs about personal responsibility. These children then inaccurately interpret intrusive thoughts as being the cause of negative events. For example, a child interpreting their negative thought about a parent as causing the car accident, or a child's belief that wishing their parent would stop arguing has caused the parent's divorce. An excessive number of negative events and propensity towards experiencing these events are more impactful and may lead to the development of OCD. This theory also suggests the use of operant conditioning in the reinforcement of ritualistic behaviors to reduce anxiety. When an individual takes on personal responsibility for an intrusive thought, they react by engaging in compulsive behavior and then observe that something negative did not occur. They're reinforced to believe that the action is what prevented the negative event. Essentially, the development of OCD serves as a protection factor for those who have experienced traumatic events. The OCD obsessions and compulsions prevent the client from being further traumatized and thus help to reinforce the development of OCD. Finally, one last researcher in 2011, Lafour, suggests that the traumatic events may not cause OCD, but rather mediate the link between the environmental and genetic expression of OCD. So in other words, the necessary environmental and genetic factors need to be present in order for a traumatic experience to trigger the onset of OCD. Therefore, the report of traumatic experiences in OCD with children may be overrepresented because the child may have developed OCD later in life without the impact of the traumatic event. So there is a lot of research on this. Most find that OCD and that PTSD are on that continuum and impact each other, which I think is really what we have found with Paul's case specifically. His attempts to remediate what happened to him and the increase in his OCD. A lot of research is still needed in that area, but there's that definite link. So we're going to move towards treatment and interventions. So for OCD, there are a lot of treatment interventions that can be utilized. So in the milieu, in the home, the use of visuals is a really helpful tool. Incorporation of interests help keep the individual attached to those resources. Nonverbal and concrete examples are also very helpful. Positive reinforcement and just the positive environment using positive psychology is a really good tool that can be used. You want to always use clear language and instructions. You want to have structured social interactions. Social stories are also very helpful to individuals with OCD. Treatment modalities. So cognitive behavioral therapy is the most common treatment modality. There are modifications that can be utilized for someone that has IDD. So this is important because oftentimes we hear from providers in the community of, oh, they have ID, they can't do talk therapy or they can't complete CBT therapy. But there are a lot of modifications. Parents can be used as coaches. Obviously, we want them to be a trusted person in their life. Utilizing that visual structure in their CBT treatment. Art-based interventions are very helpful as a modification. Utilizing things like fear thermometers, rating systems, again, increasing that visual portion of the therapy. Adopting their interests into the treatment. So I know within START's coaching program, although not a therapy modality, if we're going to introduce something to them, we often, make it superhero themed or themed towards their interest to gain their interest in actually utilizing it. So adopting that into the CBT therapy. Narratives to increase social understanding. So social stories, comic strips are all things that can be modified into traditional CBT treatment. A few other therapy modalities, so exposure and response prevention, ERP, which Dr. Kent is going to go on the next slide in a lot more specifics, mindfulness training, anger management support, and social skills training.
All right, as a New York START believer, I'm not just all about pills. So I want people to realize there are a lot of good treatments out there, non-medical, and they have proven to be very, very effective. So exposure treatment is one of them. The key philosophy behind exposure treatment is to experience the fear. The individual's likely been trying to avoid their fears for so long that it's a very scary undertaking for them. I've sent many people to exposure therapy and some are just unwilling or unable to give it a chance. It can, however, definitely be a very effective form of treatment. I thought first I needed to define habituation. Basically, that means getting used to something. Think about if you're in an office and are too near the bathroom or a lunchroom where there's no noise going on. Nothing to do with my location in Bethpage, by the way, but I just figured I'd throw that out there. Probably when you first start, it's annoying and it's distracting, but eventually you almost don't even know it's there anymore. That's the point behind exposure treatment, to get used to something and to make it less powerful and less important. You're teaching someone to avoid avoiding, basically. The science behind this is that avoidance reinforces the fear. The longer you don't do something, it becomes bigger and bigger and bigger, and it takes on more power. Compulsive rituals are also very hard to give up. As we spoke before, there's that very big fear that something bad might happen. That is why it's very anxiety provoking to move away from them. It's very common to feel worse before you get better during exposure treatment, and that's why a lot of people will back out midstream. I'm going to address the medication on the next slide, but this is a good point to say that it needs to be flexible if it's used in conjunction with exposure treatment, because the person's anxiety level will go up and down with the treatment. Now, allowing the obsessions is another difficult task. The individual may have been taught in other therapies to block the thoughts, distract themselves, and not deal with it. In exposure therapy, we want the individual to allow the thought to go to completion and take away its power. Again, a stressful intervention, but one that can be helpful. To prove that they're not totally sadistic, exposure treatment therapists use a hierarchy scale called a Sud Scale. This is the subjective units of distress scale. Basically, you figure out about 10 things and you rate them from which is the most ridiculously impossible to consider down to those which are more doable. As a brief example, if someone's very afraid of germs, you could have them walk into a public bathroom and immediately walk right out. That might be lower on the scale. Further along might be to touch a public toilet handle and deal with it. Really higher up may be to put their hand briefly into the toilet. Again, this sounds sadistic, but you gradually want the person to tolerate things, and the intention isn't to create some kind of weird, perverse individual that's going around to toilets around New York City. But if you could get over that, you could get over walking in the bathroom, needing to use the bathroom, and not even leaving your home because you're afraid that you might have to use the bathroom. Now, it may seem obvious, but I got to tell you, of late, COVID hasn't helped this any, because a lot of people are very afraid of going out and getting infections now, and rightfully so. So I have a lot of patients coming in to me and saying, you see, I was always right to be like this. And I'm like, oh, not exactly. So, but we have to address the times that we're living in as well. But the key thing is exposure treatment is very effective, and no question should be looked at as a possibility if we think the individual has the temperament and the cognitive ability to handle it.
Dr. Kent, one more question.
Yep.
So as far as for phobias where, like, I know fear of vomiting is a pretty common phobia. Can you make somebody vomit, like, for things like that? Or would you just like stop at like having them watch somebody throw up and listening to it and maybe smelling it? Or would you go full force and actually have them vomit?
No, I've had a couple like that, because by the way, that's a very common, especially in young women, high school, college age. I'm not sure why, but I do see that. And what we've done is we gradually had them watch a movie where someone was nauseous, watch a movie where someone actually vomited, might do something with smell that's possible. We could always get one of those Harry Potter jelly beans that supposedly tastes like that. But no, I've never been a believer to induce the vomiting. I think that's probably stepping over the line a little. I can't say if anybody's ever used it, because that fear of vomiting has a major impact on people. I've had people, they wouldn't go to a college party because what if someone drank and vomited? They wouldn't go to an amusement park. What if somebody went on a ride? So I would have them go to those places and walk out, but I've never gone to the point of inducing the vomiting.
Okay.
Interesting point. I think you must be cruel. All right. So, all right. Medication treatment. This is the Nicole slide. All right. Serotonin reuptake inhibitors. That is she is right. That is the mainstay of treatment. Basically, they all kind of work, and we try to look at side effect profile and tolerability. One interesting thing I want people to be aware of, because the coordinators, you go out, you get the medication list, you look them over. The dosage often has to be higher for OCD than for depression. So for Prozac, I'll give you a perfect example. Prozac, you might have a good maintenance dose of 15 to 20 milligrams. It is not unusual for someone with severe OCD to go to 60 to 100 milligrams of Prozac. So I can't tell you the reason why, but you see a much higher dosing for OCD. Now, another weird point, interestingly, in Europe, for some reason, the company that made Luvox really marketed it very well, and it was by far the #1 seller in Europe for OCD. Now, in the US, that really never happened. I love that medicine for OCD. I use a good amount of it, but it never seems to be first line, but it is a common one, and it works quite well. Now, the serotonin reuptake inhibitors, like duloxetine, venlafaxine, or Cymbalta Effexor, to use the brand name. Yes, Nicole, those actually also can be used. You don't see people go to the first line, but it can be effective. I don't think hitting the norepinephrine makes it more effective than a serotonin reuptake inhibitor. I think it's all the more, if one didn't work, let's try something different. And it may hit the ancillary or comorbid anxiety piece a little better. So if I have somebody that fails the serotonin one, I may go to the serotonin norepinephrine one.
Yeah, I was wondering if the norepinephrine could actually create like more anxiety in the person.
Well, it can. There are some people that find it too stimulating and get agitated and edgy on it. And I think to use an example is a medicine like Wellbutrin, which does enhance norepinephrine and dopaminergic functioning. So I think you have to warn the person that while for many it could be more calming and more beneficial, there is a subpopulation where you do see that. So yeah, that is a possibility.
Interesting. Thank you.
Now, clomipramine, also known as anafranil, people don't like to use that as much because it's sort of a pain in the neck, which I'll get to in a sec. It's an old-fashioned tricyclic class medicine, and you have to get blood levels. You have to check EKG. It's super dangerous in overdose. So it's really, why would you pick it as the first one? But it can be effective when others fail. Very, very calming, but you do see more dry mouth. You can see a little more weight gain, and you can see a little more sexual dysfunction than even that you see in the other ones. So that's something. I want to make a note about atypical antipsychotics. They are not FDA approved for OCD. They should never be the first line treatment for OCD. They're on this list for two reasons. Number one, they can help if you get only a minimal effect from the other ones that are approved. Sometimes it can be a booster and you can supplement the effect. So I don't want to say never use it, but I've learned in working with START that unfortunately it seems to be the first line for the common cold, sometimes for everybody out there. So somebody has autism or IDD, I think sometimes they're afraid of agitation and they go to that as the first line. I don't think that's ever acceptable. I do think it's acceptable to end up on it, but I'd hate to see that be the first go-to unless somebody clearly was calling out for that because of their dangerous behavioral health symptoms. Now, benzodiazepines. These are Xanax, Ativan, Klonopin, Valium. OCD is difficult, and I think Elise kind of mentioned you will see other anxiety symptoms with it. You'll see panic, you'll see generalized anxiety, you'll see social anxiety. Because think about how difficult it is to navigate the world with severe OCD. So with that in mind, I will use the benzodiazepine to supplement the other medicine, because if we can calm down the anxiety, they may be more comfortable to face their fears. They may be more comfortable to do the exposure treatment. So they could be used well in combination, but again, it's not a first line. I think with the exposure treatment, it's tricky because I don't want to use a benzodiazepine so much that they go for exposure treatment and oh, this is cool, I don't give a damn. It's like they had 3 drinks and they're fine. So I want them to feel it, but I don't want them to feel it so much that they avoid it. So it's a good idea to have communication between the exposure therapist and the provider with the meds to sort of figure out, hey, this week, what are we going to do? All right, let's do this. And I've even had exposure therapists have a PRN in the office and let them take it during the exposure therapy so we can titrate it up, pull them back a little bit, and work together in conjunction.
Is the medication that Paul is on a benzodiazepine?
The PRN at the kitchen table that we were talking about was clonazepam. So I'm assuming he's on a benzodiazepine PRN, but someone could correct me if I'm wrong.
Okay.
Heather, do you know if that's what it is?
He's on hydroxine.
That's what he was on. That's a souped up antihistamine. So I certainly don't love that as the PRN. I thought we had talked about using low dose benzodiazepine just as needed, and mom got comfortable with it.
We did. And then she became uncomfortable with it again. So it's ongoing. Right. It's ongoing. Education here and there,
I told you we should put it in the Poland Spring bottle, but nobody wanted to listen to me.
Okay. So moving towards trauma-related treatment. So to start, there's a lot of milieu interventions. So whether it be in the home, in the school, in group homes, day programs, wherever they might be. And the first thing that really needs to happen is the individual themselves need to feel respected, informed, connected, hopeful about their life and their future. It's really important for the caregivers to understand the interrelation between trauma and symptoms of trauma, such as depression, anxiety, irritability, low frustration tolerance, and OCD. The need to work in a collaborative way with the family and the paid supports, all in the manner that empower the individual. The individuals need support in learning how to build appropriate and lasting relationships. And the individual's task can often be supported by breaking down their tasks into small goal-directed expectations. I also want to just very quickly explore trauma-informed care. So this is something that it's not a treatment modality, but it's really important for the environment surrounding the individual that has experienced trauma to be supported by the 5 core values of trauma-informed care. The first is safety. So this value focuses on ensuring the individual themselves feel safe in their environment. It's not just a physical safety, but also an emotional safety. So sometimes we'll talk to systems about this and they'll be like, well, we have, the sharps are locked and the doors are, alarmed. And again, that may help them feel safe, but it's also that emotional safety that's really important, as well as that physical safety. If the individual who's experienced trauma does not feel safe in the environment, the symptoms will develop as a coping response to establish their own feeling of safety and control. The second core value is trustworthiness. So the individual needing to trust those around them. Without trust, they will not be able to engage and work with their supports appropriately. Trust is extremely important for someone who's experienced trauma. And keep in mind that with some individuals, their perpetrators were people that they did trust, which will make trusting others even more difficult. Even if the perpetrators weren't the people that they trust, such as in Paul's case with the bullies, the people surrounding him did not keep him safe. And ultimately, those teachers and those school administration that he previously had probably trusted no longer fulfilled that trustworthiness for him. So that does, make things more difficult as he's working with staff now or people that are supposed to keep him safe outside of his family. The third core value is choice. Someone who's experienced trauma had their right of choice taken away from them, which makes having choices now even more important. Allowing the individual to make decisions for themselves is really important. For Paul, there's a lot of ways that choice was obviously taken away from him, but one of them was really that move for schooling. He ultimately had to make a decision that may not have been best for his academic success, for his mental success, to get removed from the environment that was extremely traumatizing. The fourth core value of trauma-informed care is collaboration. So this is definitely related to choice as well. Someone with trauma wants to be involved in the situations surrounding their life. They want to be part of the process, as prior that ability was potentially taken from them. And the last core value of empowerment. So rather than being the voice for the individual, we want to support them and empower them to find their own voice, to advocate for their own needs. Similarly to other core values, they want independence and choice and to be a part of the process. Part of that is supporting them to feel empowered. Going back to some of the treatment factors. So there's a lot of coping skills that can be developed in someone that has experienced trauma. One of the things that really needs to happen with the people supporting them is always using a calm tone of voice, a neutral demeanor. It's really important that you're portraying that calmness for the individual, even if they're escalating. Reminding the individual the positive aspects of their life. This is really important for them to feel as though they have had success, for that they have positive things going on in their life, that they have achieved things. Engaging the individual in preferred activities is always of importance and helpful as well. Short-term goals are really helpful, helping them think about things they want to achieve in the short term rather than thinking too long-term can be very helpful for somebody with a trauma history. Verbal praise, again, going back to that positivity, is also very important. And engaging the person to express themselves appropriately and help them be a part of that process. Some therapy techniques, so cognitive behavioral therapy for trauma. So we talked about this for OCD, so this is an overlap. CBT is also very helpful for trauma. So it is a psychotherapy technique and modality that has consistently been found to be the most effective for the treatment of PTSD, both in the short term and the long term. CBT for PTSD is trauma focused, meaning the trauma events are the center of the treatment. It focuses on identifying, understanding, and changing thinking and behavior patterns. CBT is an active treatment involving the patient to engage in and outside of weekly appointments and learn skills to be applied to their symptoms. The skills learned during therapy sessions are practiced and repeatedly utilized to help support the symptoms improvement. The same modifications that I presented for OCD treatment can be utilized in this population of people with IDD in receiving PTSD treatment utilizing CBT as well. So modifications can still be utilized. There are several different specific CBT modalities for PTSD, but one I want to highlight is eye movement desensitization and reprocessing, EMDR. This is an 8-phase client-paced exposure treatment that utilizes rapid eye movements or alternating hand taps and tones in a left, right, left sequence to ameliorate anxiety, fear, intrusive images, intense sadness, anger, and dissociation, as well as other symptoms associated with trauma experiences. The approach focuses on affective, cognitive, and somatic perceptual components of trauma in order to expedite the accessing and processing of disturbing events and to desensitize stimuli that trigger present distress as a result of second-order conditioning and to facilitate resolution of memories. And I just want to note that EMDR has a lower focus on talk and communication. So it can be very successful for the IDD population, given that they do have the communication deficits in their expressive and receptive factors. And Andy, for hyperarousal treatment?
Yeah, we talked before about the limbic system and misinterpretation of sensory input. So you get hyperarousal, and why that's important is you don't want to just jump into cookie cutter OCD treatment when there is trauma associated with it. So let me give a little blip on that, and then you'll see what I mean. The person is very heightened when they re-experience trauma and they have hyperarousal. What I mean by that is their blood pressure may be up, their pulse may be up, their body is on guard. Now, if you use the antidepressants, which we talked about, the serotonin reuptake inhibitors, well, the person's going to obsess less, right? Which is a nice thing, but it doesn't get at that core hyperarousal. If I give a benzodiazepine, well, it's kind of like a shotgun. Yeah, they'll feel calmer. They'll be a little more relaxed, but you could make them tired and you could give cognitive blunting. So in this population, there are alternatives. If anyone's familiar, one of them is propranolol. Propranolol is a beta blocker. It's used off-label to prevent the brain from sending the message of panic to the body. It basically blocks the heart from going too fast, blocks the breathing from going too fast, and blocks the body's muscles from getting too tense. In a sense, you're creating a disconnect between the mind that's saying, hey guys, time to panic, and the body which is saying, I don't hear you. I'm sorry, I'm not panicking. It's nice that you're upset up there, but I just don't hear you. Generally works even better when you have a motivated patient who understands that, because it's a little confusing to someone who doesn't. Like, why aren't I freaking out? Like, I should be freaking out here, but I'm not. So, but very, very effective. And I've used it for people, even if they're panicking about their first performance in public, with music or a big presentation in front of people. Their mind is telling them you should panic. And again, you don't want the body to. And then the other option is Guanfacine and Clonidine. They work on different receptors, but essentially they do something similar by keeping the blood pressure under control and not letting the body get hyperactive from adrenaline, which is why when you think about it, these are FDA approved for ADHD, impulsivity, and the tics of Tourette syndrome. And by the way, they're also used for detoxing people, because what happens to the body when you're detoxing, it goes through its almost hyperarousal state for a different reason. So take home message is, if somebody has OCD and trauma, we may want to talk with their providers and their system about making sure we address the hyperarousal on top of the OCD.
Thank you. So anyone have any questions that haven't been answered? Okay. Anyone have any specific recommend? Oh, absolutely. Go ahead.
Sorry, it wouldn't be a CET without me at least having one question. Right? So this is a lot of information to digest. I guess one of my questions is, like, how do we bring this all back and support Paul? Specifically, I'm wondering, how do we help his family help him without further exacerbating any type of adverse behavioral health incident? What might be some constructive first steps?
Yeah, so that was actually going to be the next thing after I made sure no one had any questions, is how can we relate this back to Paul? So I think that sets us off on a good point of what did people learn that we can relate back to that case that we reviewed with Heather.
I don't recall in the document, Heather, but I'm sure you can let me know if Paul had undergone any specific therapy or services to address the bullying he had experienced in his younger years.
So he is in CBT therapy, but I mean, one of the recommendations that I've continuously had is having, a trauma-informed kind of care approach and, maybe ongoing collaboration with his CBT provider and, addressing and focusing on the trauma he experienced. It seems like the family often brings it up as, a significant point of his life, and understandably so, but it seems like they haven't really explored ways to really help him process what he went under, more so just fix the OCD symptoms that he's currently experiencing. So it's kind of like, bringing this information back and how the trauma has impacted his OCD, I think will be important in helping them understand how, processing his past trauma would be a really good way to approach, the symptoms that he's currently undergoing. Did that answer your question?
Yeah, definitely. And I just think also like posing it, I'm sure you already have because you're really smart, but just like posing it to the system, like in my mind, I see it, and most people I think would agree that for Paul, it sounds like a lot of the root cause is the bullying. So like even creating like some kind of visual for the system, explaining like the root cause leads to the symptoms of OCD so that they can further understand the importance of really addressing the trauma. Because it sounds like a lot of his symptoms just kind of happen, and when he's heightened, they continue. But if he's not getting to the trauma, then it's really, it's going to be like a continuous cycle, which I'm sure you know. But I don't know, like I think the visual, the way I see it in my head at least, might be helpful.
I think so too. And I think it's important for, sometimes in the moment, they might be like watching this or, education and stuff like that. Verbally might be a little bit hard for them to process. So something, concrete that they can rely back on will be very important for them.
I know it's 12 o'clock and we have to go, but I feel like with the extensive psychiatric conditions within the house, his environment can be really toxic. Like he can do all this work in therapy and with medication, but if he's in this environment where everybody else is, dealing with their own thing, I feel like that could be a huge barrier. Are his sisters and father, are they in therapy? Are they getting treatment?
His father is, his mother is. I'm unsure about the sister. I haven't had much interaction with her, but I know it's important for them to all continue with their own care too. But I think mom sometimes very much focuses on Paul's care, and she can get a bit sidetracked on her own. So, I always just encourage her to have her own self-care, take care of herself and stuff like that. But it's definitely an important aspect to focus on, And I know one of Paul's goals eventually is to, be able to live out on his own. So being able to kind of, prepare him for that in the future. And I think it'd be good for him to be in an independent environment, with supports and stuff like that.
This reminds me so much of one of my other cases. That's why I'm like so invested. I have this individual on my caseload that just is like, there's so much going on that's very similar. And I wonder like if the family, because I don't know, but when he engages in these rituals or compulsions, like how do they respond to him? And I'm just wondering like if they try to redirect him, or if they like, how do they respond?
So I know particularly with his dad, sometimes they undergo OCD rituals kind of around the same time. And sometimes that causes a lot of stress for Paul. And, that's particularly when his verbal aggression will come out, is if somebody's interrupting him, or for instance, I know the other week, the gate for the dog was up and it got in the way of his ritual. So that's particularly when, he will experience those aggressive side effects and stuff like that. So yeah, it definitely is. They all impact each other. It is hard, I think. And that's really where you can see some of his concerns kind of be brought up.
Have we ever done coaching with them? We can get
We
in there.
We have,
Oh.
but it started, I think prior to the pandemic, and then it went to virtual, which was a little bit harder at least. But, you know, a lot of the things that we brought up was some sort of, you know, meditation, maybe going on walks, creating playlists to, I think one of the main concerns he had at the time was in the shower, his rituals, and he was having extensive showering. So maybe some playlists and music and focusing on, you know, what calms him down. And kind of including it throughout his day, especially with the increased time spent at home.
Do you think his family would read books on how to approach him? I have like a whole list of them.
Yeah, of course. I think they would be willing to. I'd probably have to follow up and just make sure that they, you know, did their research and stuff like that. But yeah, no, I think anything honestly to be able to present to the family would be helpful.
I'll send them to you.
Thank you.
Okay. So I know we're going a few minutes over, but this discussion is great, and we definitely have a lot of great feedback for the system. So thank you so much. And Heather, you kind of just went through a list of things that you're going to bring back to the system already. Was there anything else besides what you've already mentioned that you wanted to kind of bring back to the system as some recommendations that you learned through the discussion and through the training?
Yeah, one other thing, I know the mom actually, and I have been discussing this recently, was the exposure response therapy. I think she's been doing a lot of her research, and that's something she's been interested in exploring. So that's something that I think we're going to be looking into a little bit more. You know, ongoing, I think education and training is really important for them, especially on medication management, but also ways to, like, you know, structure his home environment and his day in order to make him as successful as possible. And, you know, most importantly, addressing that trauma, I think is really important. And I know one of the things that's been on the psychiatrist radar and my radar with collaborating is maybe, you know, exploring the official diagnosis of PTSD, which I think was missed for a while. So.
Absolutely. Absolutely. And I know that we, like I said earlier, we discussed kind of adjusting this training and potentially supporting the mother in some of these topics, because I know she's always eager to learn, as well as with the other caregivers in his life, his comhabs. You know, he's luckily been able to develop a really trusting relationship with them. And I know you've worked with all of them in various ways, but the more information that they have, you know, the better they can work with them. So with him. So I think that will be a great opportunity. And just before I end us, I want to thank everyone for joining us. I hope this was really helpful in exploring this topic. And on the screen for the last couple of minutes has been our upcoming clinical education teams for the next few months with the topics. And anyone that would like to be on the invite list, please email our office manager, Shirley, and her email is also on the screen. So I thank you all for joining us, and I hope to see you at future CETs.